been difficult to find a reliable diagnostic tool for SLE and connective tissue diseases because the current paradigm relies on ANA and double-strand DNA, which alone do not provide optimal sensitivity and specificity for diagnosis.
ANA, anti-nuclear antibodies, is a very sensitive test, and depending on the study, the lab, the type of cells that are used, the sensitivity can range from 90 to more than 95%. However, because the test is so sensitive, this comes on account of specificity, and the specificity of diagnosis of ANA for connective tissue disease ranges around 53%.
The weaknesses that ANA may have are in the specificity. Patients with a positive ANA not all have lupus. Double-strand DNA testing is a highly specific test, up to 97%. However, its sensitivity may be as low as 30% and may generate false negative tests.
That means that if the patient is negative for anti-double-stranded DNA antibodies, not by a long measure does it mean that the patient does not have lupus.
Anti-Smith antibody is helpful in diagnosing lupus in that it is specific to as high as 100% in some studies. However, just like double-strand DNA, its sensitivity may be as low as 15%.
So we discussed some of the diagnostic limitations in using ANA and anti-double-stranded DNA antibodies for the diagnosis of lupus, and CB-CAPS or Nevise 2.0 overcomes these limitations. So with the poor specificity of the ANA and the poor sensitivity of anti-double-stranded DNA antibody, the Nevise 2.0 has a more balanced performance with a sensitivity of about 80% and a specificity of about 86% for the diagnosis of lupus. Therefore, with this test, we're getting many fewer false positives than with the ANA test and many fewer false negatives than with anti-DNA or with anti-SM.